We are on a mission to save and revitalize independent pharmacy.
On the Catalyst Pharmacy podcast, you'll get actionable business advice.
Hear stories from industry leaders.
And share a laugh or two with us.
Fuel your passion for pharmacy.
One conversation at a time.
4,
3,
2,
1. Ignition.
Welcome to the Catalyst Pharmacy Podcast. I am your host, Mark Bivins, Vice President of Sales for Pioneer X. Today, I am here with Josh.
Hi, I'm Josh Howland, Senior Vice President of Clinical Strategy and Development.
Today, we're here with Megan Smith, Assistant Professor and Residency Program Director at UAMS College of Pharmacy and Co-Network Facilitator for CPESN Arkansas.
Hey, Megan, how are you?
Hello, I'm fantastic.
Thank you for being on with us, Megan, and we're really glad to have you. I know you're like heavily involved at the CPESN piece as well. I think you're a co-facilitator there, but also obviously Arkansas University as well.
Yes, absolutely. Thank you. It's great. It's a pleasure to be on today. Thanks for the invite. I didn't know what to expect, and so this morning, we're just going to find out what we do. I said, okay.
Yeah, we're going to learn about you, talk a little pharmacy.
Like, I'm used to having a slide set. You want a slide set? You want a presentation?
We could do a slideshow later if you want. Like if it starts to lull a little bit, we can break out the slides. No problem.
True faculty right here.
Right. We can look at we can look pictures of our kids, your kids, my kids,
right.
Like either way.
Yeah. Our podcast is much more geared toward just winging it.
Yeah. Yeah. And if there's anything non-pharmacy related, Ted Lasso, The Witcher is coming up soon. I don't know if anybody watches The Witcher, but anyway. All right. No, that's okay.
I watched and this is the random spot. I will watch anything that Henry Cavill's in.
Oh, you like Henry Cavill?
I spent 20 minutes watching him build a computer
He's
on the internet.
He's the Superman guy, right?
Yeah. And The Witcher.
Oh.
Yeah.
Okay.
He's got this great, he was in Mission Impossible, 74. And there's a scene where he's about to beat the crap out of Tom Cruise in the bathroom, and he reloads his biceps. And Tom Cruise loved it so much that he made Henry Cavill do it on all of the press,
the press tour, all the press.
Yeah.
Oh, okay.
So
nice.
there are hundreds of internet memes of Henry Cavill reloading his biceps.
Man,
it's worth a watch.
Wow.
I feel like there's a love connection there.
There is. He's fantastic.
Yeah, there is. He is.
He's not the reason that the Superman movies were terrible.
I feel left out because I don't know. But I do know. I'm very familiar with Ted Lasso. Love that show. We're not keeping up well with what episode we were on, and we were watching it every weekend, and we missed one. So then we would kind of do a few at a time. My mother and I were watching them together, and we got to the end of the show, and I was like, that's not it. That can't be the season finale. No, I think that was the last one. Mom's like, do you have to wait for a month? I said, no, a year.
How does this work? Why is it doing this?
It comes on again. We're like, oh no. Our expectations we were not emotionally prepared to be done.
Yeah, you get really invested in it. So if, in favor of potentially prepping for a round 2 of this, what are your predictions for Ted Lasso season 3?
Oh.
I think and I was kind of surprised it didn't happen in season 2, but I am waiting for when he goes back with his son to go make a trip back to America.
Mm-hmm.
There's something's got to happen to bring him back over. I feel like that's something in season 3. I'm not saying that that he's leaving the team, but that somehow the team or something he comes back into to US of A at some point. I think the whole love affair thing. I think that's just going to. I don't think that's going to sustain. But I'm glad Sam stayed with the team, but I don't think that it's going to be forever for them.
It's going to fizzle.
All right.
What are your thoughts?
So, season 3 is clearly
we'll talk about pharmacy. I promise. Give us a second.
I think if you think about season 1 was kind of in Star Wars terms, it was the New Hope, right? And then the Empire Strikes Back. Nate's the evil guy now. You got to come back for the 3rd season. They have to win in the Premier League. They have to beat West Ham, and they have to bring Nate back into the fold.
Nate is gone. I don't think he's going to come back.
No,
You think he's going to come back?
I think I hope he pulls a Jamie Tart kind of redo. But
Yeah.
It took a while for me to come back to warm back up to Jamie Tart. And I feel like I'm very hurt by Nate right now. I don't even want him back.
Yeah.
Very hurt. I'm very hurt.
It's funny though, because you kind of saw flashes of Nate's insecurities through all 3 seasons, but like, or both seasons, and you're just like, it just boiled over. It was wild.
I was really shocked about how far he went. And it felt quick like in the moment, but but you're right. There was a lot of foreshadowing and small things happening, but I was shocked by that ending.
Dude, next year for Halloween,
Are we Ted Lasso? Ted Lasso?
One of us can be Lasso, but one of us has to be Trent Krim of The Independent.
Oh,
Exactly.
Yeah. I don't have the hair for
Josh,
that.
that's got to be you.
Yeah, I don't have the hair for that, clearly. Like,
I'll start
Josh
growing
is
my
the
hair
I
now.
have to get a wig. Like, even then it'll look weird.
Josh is Trent Krim.
Only if you grow a mustache.
Right, yeah.
But he's not with the Independent anymore.
That's right.
Yeah, he truly is independent.
Truly is independent.
And
You can tell he is he's a newer dad, so he's like got the dad pun jokes.
Yeah.
Finally loaded.
The dad jokes are strong.
Newish, not super new, but
Yeah, I've had 4 years to get into it.
yeah. So usually, what we like to do is just kind of like, can you give us a little bit on like your journey into pharmacy? Like what even led you to, hey, I think I want to go to pharmacy school in the first place?
Yeah, that's a great place to start. And my journey begins way back in high school, like I think a lot of folks. But I did not know what I wanted to quote unquote be when I grew up. But I did work at a community pharmacy since I was a sophomore in high school. I liked my job. I was the customer service representative, to put it nicely on my resume. I was like, what do I say? I answered the phones.
Right.
But I answered the phone. I talked to people as they came in, took their prescription, checked them out, processed sales. That's how you put that on a resume.
That's
so
right.
I ended up working 2 years at a laboratory company. I was a lab tech, used my chemistry background to degree analytical chemistry, and did HPLC and mass spec, and just like worked on the medications. And we put all the packets together for FDA approval for different generic options for prescriptions. And so I worked at the lab and found pretty quickly that did not suit my personality very well. I was like, I really want to be back talking to people.
I was going to say that is the opposite of what you enjoyed at the pharmacy, probably. So now you were scanning and working away.
Exactly. So anyway, so then I started to change my question for what I want to be when I grow up to what do I want to study, what do I want to learn about. And so I looked at programs more of what classes would you take. And someone, again, somewhere along the road mentioned something about pharmacy. I'm like, well, I don't know. They don't talk to people that much, but let me figure out like what it is. I looked at what they had to study. I loved all the classes. It was just enough of kind of I got to know a little bit about everything. It was very general. It felt like you could do a lot with that field. So I started to interview other people in hospital administration and just pharmacists that were around the city I was living in, and asked them about the future of the profession. What could you do with it? So really putting my due diligence into finding out more about the profession as a whole, and seeing the variety of that caught my eye. And I liked the fact that I learned a little bit of everything. I wasn't getting a PhD and how this one molecule worked. It was
I see.
So that was attractive to me. So that's what led me to pick pharmacy school. And throughout the pharmacy education, I was trying to figure out again, okay, which area then now is for me. And I kept coming back to community pharmacy because there was nothing. I didn't really feel like I fit in a box of a specific disease state to become a specialist. I always liked teaching, and I'd always led our study groups, but I thought that was something you did when you retire, like when you're old. I wasn't sure that was a career path you could do like right away. So I didn't learn about that until later into my residency. But the community pharmacy aspect, I love the interaction with people, and that every day I could be interacting with new folks. And I just, I liked being able to usher them. Like my favorite activity was counseling on over-the-counter prescriptions. The amount of teaching that I got to do with that, because They
Wow.
are making decisions, and I can tell them something today that they're going to do next time they have a cold and the next time that something happens. And I love that interaction. So I decided to do a residency to help kind of start my career as a community pharmacy manager specialist. I wasn't really sure where it would end up. And during my residency year, I kept kind of that little light about teaching kind of in the back of my mind. And one thing that residency opened my mind to was scholarship and research. And I came from that laboratory background, and I was like, I don't want to be in the lab anymore. That didn't suit me. I want to be out with people talking and helping and facilitating. And so they, the community residency program showed me that research doesn't have to be in the lab research.
Right.
There's a whole lot of different kinds of research, and what's the type that we do with community pharmacies. So it lit a whole new fire in me, and kind of really is what turned my perspective. And can I do this now? Because I saw such a need between some of the scholarship and research that was happening in the pharmacy profession was happening in our health system setting. And when I was looking at the history of just how did we get out of the basements, essentially, how did we get out of the basement of hospital pharmacy and onto the floors? There was a lot of partnerships with academia and a lot of studies that came out of that showing the ROI and what are they doing, what types of interventions are they doing. Mm-hmm. And I'm like, where's the community pharmacy piece for this? And I was in my residency, so I was there at a pharmacy day in and day out. And I thought, there's so much work to do, and how I can't take care of my patients and and filling everything and work on these long-term, how do I show that it's worthwhile, all the things that we're doing? And so I was like, from that, I thought there has to be a way and more relationships and connection with academia and partnerships with academia and community pharmacies so that their story can be told. And so that's how I summarize it to most people, as I view my role as telling the story of community pharmacists and the major impact that they're having on their communities every day. How do we bring more attention to that? How do we bring more tools and resources to them? Like that's what I'm doing every day.
So if I remember, you went to University of North Carolina, correct?
Yes.
So did you do your residency there in North Carolina as well?
Yes, I did. My residency was at the UNC Ashelman School of Pharmacy. They have multiple site partners. My site partner was Car Drug in Asheville, North Carolina. And so I went to Asheville and I got to work on the Asheville project. So
what is that?
I'll bring that into students.
I don't know that. I don't know what it is.
It's big.
Yeah. It's cited a lot of saying that pharmacists have an impact on chronic disease management and we can save money. So it's the city of Asheville put their city employees on this program where they have to meet with the pharmacist once a month and they get benefits of reduced copays or free supplies. And then it's showing that if those folks who saw the pharmacist once a month, that they actually lower total cost of care for their diabetes and hypertension services.
I see.
So it gets cited quite a bit. And so it's really neat that in one sliver of my experience, I was like, I could be a part of that. And I was one of those providers at the Asheville project. And so, yes, all of that happened in North Carolina. My residency was in Asheville. Then directly after my residency, I started a community pharmacy fellowship. Again, that fire of what is research? How do we strengthen this relationship? What's the type of research and scholarship that we need to enhance community pharmacy practice and show people what's actually happening? They're not just counting pills.
Right.
So how do you do that? And I felt like, well, that's the area that I have the least amount of training in. Pharmacy school doesn't prepare you to be that type of faculty or researcher. And so I decided to it wasn't just me deciding, but I kind of pushed for it and said, look, I'm really interested in a career in academia. I feel like I needed more training on that. On that side, I felt like my residency really helped me improve my clinical skills. I felt like I was a legit clinician, that I could be a pharmacist. I felt like I had that part, but I didn't have the research part. So I completed a 2-year fellowship, a community pharmacy academia fellowship at UNC, Ashelman School of Pharmacy, so back with my alma mater. But what was really neat about that experience, what kind of funded the fellowship ended up funding most of the fellowship was the Centers for Medicare and Medicaid Innovations Grant to Community Care of North Carolina.
Oh, okay.
That was awarded in 2014, and that's when I started my fellowship. And so my fellowship was 70% of my fellowship was paid through that grant. In that I had to work, of course, on that as a sub grant research assistant in there. So I helped with field testing and assessment, quality improvement, just really field site training and assessment.
Sure.
So working with those that were dubbed the first CPESN, and
Right.
what does that look like? How did all that bring together? Who are they? What are we all doing? And so I was on the kind of the ground, calling and talking to all of them of how are they doing care planning? What are they doing? How are we documenting it? And then creating some ways for us to measure their impact. So that was my fellowship, which has just catapulted or just kind of made my entire career path. And I'm still now working with a great group here in Arkansas, and that CPESN has maintained and has grown to be what it is today. So it's really neat to be a part of that first kind of, what is this group, and see it blossom from the very beginning roots to now.
For sure. What was it like? I just had a question about, like, you were there at the kind of the beginning of introducing care planning and things like that to pharmacies. What was that like, and what tools were you using to help pharmacies capture the data you guys needed to capture for the purposes of the grant, or to show whatever outcome you guys were looking to show?
One of the things that I spent a lot of time coaching about was just the reason why. Why do we need to even write this down? What does it matter?
Why am I doing this?
Right.
Yeah.
And to be fair, that's still a question we're answering all the time.
Right? Yeah, we're still answering that. It's like, why do you want to do that? So that's something even from 2014 to now. And I think it's just a growth. I think it's a natural growth of when you start doing, transforming this in your mind. It's a very much a perspective change. This is not a technology change. It's not, it's not a technology change. It's a big thing. People think, oh, it's just a light switch. I flip it on and I'm just going to click these two new things and I'm done. It's like, no, the entire thing is a perspective change on what services are you doing and what are you providing, and getting credit for that is kind of the way I put it. It's like, how are you getting credit for all the things that you're doing besides putting the pill in the bottle? And then what do you want to do, and what do you want your business to be about? And community pharmacies are so, and the pharmacy out there are so well primed with data that you see through your prescriptions dispensing software, through Pioneer, whichever you're using, that you can see your patients, what they're getting, when they're getting it. Like, you have so much insight into how they are using those medications, and that's what brings you, makes them special, makes you special, makes the community pharmacist special, and makes them information that they can take and use and transform a direct patient care, and saying, hey, this seems odd for you, or this one's up for you. And you can use and mine that data rather than being it just kind of there. There's just a unique perspective with that community pharmacist, I think, can provide, with the amount of information we know about patients, and then of course the amount of times that we see patients. But it's that whole, why am I doing this? And I think it's getting easier now. I think folks are really starting to see some of the fruits of the initial efforts, that we have national payer programs. Yes, they're low-hanging fruits, but we have some national payer programs, like taking note and saying,
you got to start with the low-hanging fruit, right? You can't go after the really hard stuff first.
And to use your own words, it's helping, that care planning they're doing. It sounds like to me, you guys both correct me if I'm wrong, you're telling a better story.
Yep.
Right.
It's exactly what you're doing. It's not just, here's the prescriptions they get. It's that extra documentation you're doing, or the documentation your system already allows you to do inside of it. Tell that better story to that payer, to whoever's going to be on the hook for that bill if that patient goes into the hospital because they're not adherent.
Right. And so one thing I kind of want to pop back a little bit on is, like, when I was in pharmacy school, I had a professor who was like 85, super, super nice guy. He'd been around and been everywhere, right? And he said, one of the things that you're going to realize about pharmacy is it's such a small world. And like every time you kind of go into a different place, you realize that that's true,
That's
right?
super true.
A lot of the stuff that we do about care planning and how we structure care plans and how we document them ties itself back to early CPESN and CCNC and pharmacy home. And then you find out that one of the more successful Flip the Pharmacy cohorts has roots in North Carolina and CCNC. And so, you know, a lot of the things that we both came around, now we tie that little spider web back together and, hey, look, Megan was one of the early people in translating CCNC into what is now CPESN and Flip the Pharmacy. All of us using information off of Community Care of North Carolina.
Exactly. Yes. And one thing that I had to dispel a few years after was here, a lot of Arkansas pharmacists, this buzz was going around, and it finally got back to me, and they're like, "Oh, they sent Megan here."
They sent me.
And I was just like, "Nobody sent me here."
That's so good. They sent her here.
And let's break that story up. How did you get to Arkansas?
Yeah. How did you?
Yeah, well, you know, the fellowship opened my eyes to, and made me feel more confident that I wanted to go into academia. I felt like that is where a lot of my strengths aligned, and I wanted to be a partner to community pharmacists. And I, you know, at the time I didn't want to be tied to one location. I was like, I think a cohort of people, like a lot of people need someone to just sit down and do the hard work or the time consuming work of coordinating all of these efforts and making the resources and updating everyone. Like we need that. And so I didn't want to have a position that was like, you have to work 20 hours at this one place and you're the pharmacist responsible for these things. I'm like, that's great. That's going to help that store. But I really want to do something that would help more stores. So at the end of my fellowship, I felt like I had a very specific dream job
Yeah.
I wanted. Like, I want something that's full-time in academia, that's not tied to a pharmacy, but I can spend all my time in the pharmacies.
Right. And community pharmacy focused. Right.
Yes. I was like, it's so specific. But I was just like, I don't know where I'm going to find this job. And so I was just doing, looking on listservs, seeing what jobs are being posted, trying to use my network as much as possible. But it was February and I graduated in June. And so, and I hadn't had anything lined up yet. And I was getting really nervous. The networking and people thought I was doing really interesting work, but they didn't have a spot open at their institution for those that I talked to at that point. Well, February was my last conference that I had on my schedule, and that was at the National Medicines Academy, like in it's like the OTC group within AACP for faculty who are teaching self-care. And the only reason I got to go was because my fellowship director was on that planning committee. It was about having that even exist. And she's like, here, you can take my spot because you normally have to like present something to go. Like everybody, that was a requirement of the conference. Everybody had to present either a poster or a podium. And so I took one of her podium spots. And so I was the only trainee there. Everybody else was a faculty member at a college of pharmacy. And so I happened to be in this like little fish and all. They're like, I want to be you. Like, what are you doing? Where are you going? So it was a great opportunity to tell people what I wanted to do. And I happened to sit next to Rachel Stafford, who is on staff here at UAMS. And she and I just got to talk about things we were passionate about with community pharmacy. We were on the same wavelength, and we were like starting to already become best buddies. And she goes like, so where are you at? What are you doing? And I'm like, no, I'm looking for a job. I'm looking for my next place.
Right.
She's like, we have a job like that. I said, you do? I'm like, how is it an
That's
hour
so
later
good.
in our conversation and
Right.
you just now know that you have a job like that? But so she told me about the position at UAMS. So before that meeting ended, I had a chance to briefly meet Amy Franks, who is the department chair and part of the search committee. And so that's kind of just, they sent me the position description and I applied and then came out here and interviewed. And it just felt like, if I could have written, which somebody actually told me to do, they said, write your job description, like write your dream job and write it out, write the whole position description. I did it in my head, but I never actually put it to paper. When I got the position description that UAMS was looking for, it was exactly what I would have written. Like, this is it. Nice. This is what I want. So it really was just a great find, and I found it through being at that conference and talking with her. So it was posted. I just had never found it. So I was at the conference and texting my husband every time I met someone that I would kind of, ask about positions open or whatnot. And I would send them, I was like, so what about Arkansas? Like, I'm talking to Arkansas now. And I was like, Puerto Rico might have something. And I was like, oh, California has something. They're interested. Let me go talk back to California. And then I came back and I said, hey, Arkansas sounds really good. What about Arkansas? And he goes, what happened to Puerto Rico? Like, can we go there?
Right.
Like, we wanted to go to he wanted to go to Puerto Rico. But I was like, no, Arkansas. And then we had to go back and look at where it was located because we both had no clue. no clue where the state was. But once I came out here for the interview, met everyone at the college, it just felt like the right place to be. And it's over and above my expectations. The folks, everyone here in Arkansas has been so welcoming, and it's been the amount of collaboration between the Arkansas Pharmacists Association and the college and the community pharmacists themselves. It's just phenomenal, and I just feel really grateful to be part of that circle now.
Yeah, actually at NCPA, I went and had dinner with Scott Pace, and he's been on the show twice now.
I think he's one of the few two-timers.
Yeah.
Yes.
And, one of the things that he's really proud of, and obviously he's been part of a lot of it, is, like the legislative action that Arkansas has taken, the way that the State Pharmacy Association really advocates for independent community pharmacies, and then really how they responded to COVID was kind of the perfect model of what you want a community pharmacy to be able to do in a public health situation, right? And it's just like, there are very few, if any, states that are like Arkansas, and many more states should want to be like Arkansas, which is not a phrase I thought I would have uttered a year ago.
Yeah, it's funny. Earlier today, today, the ACIP is, I know this is not going to make sense with whenever the podcast is live, but today is when the ACIP is meeting about the Pfizer pediatric vaccines, and so we're seeing little bits of information leak through, and I had to call our lead for the CPESN federal pharmacy program because I was getting confused. I was like, okay, some pharmacies are getting emails, other pharmacies are not getting emails, and I need to know which ones are getting what and where to help this. And he just laughed. He says, oh, it's Arkansas. He's like, y'all's team are so strong. I'm like, I know, you send out one thing and we are group texting about
everybody
it.
already
the next
knows.
5 minutes.
Right. Yeah.
We are, it is. And so when folks ask me that, and I've had folks from friends and mentors and colleagues from North Carolina asking me how does Arkansas do it? And there is no, in most things, public health and how we're responding to the pandemic and all of that, there is no competition. We're all in this together. Everybody's on a call at 8:00 at night. We're all trying to figure it out, and we're all sharing information. Like, that's
such a good mentality
culture of Arkansas pharmacy. There's obviously some competition somewhere, but like
sure.
For the most part, it is just, we are all, let's roll up our sleeves. Let's figure out the best way that to get this done, whatever it is. And the pandemic for me has shown me how impactful group texts are. It's like, I text everyone now. Like, half my life is texting on my phone. So.
I love it.
But yeah, they need it. I mean, the pharmacists are grinding every day and having to answer, pressure and questions from the public. So the reality is they don't have as much. Even though they've probably have 3 emails about it, in their email, they need an easy button. That's what I call my text messages. It's the easy button. Everybody's like, I'm so sorry I'm bothering you. I'm like, don't worry, it's the easy button. I've got it, and so they will text me, and then I just text them back what they need. That's what I've learned through the personally of how do I help support this network? It's, they need someone to be available, and that they can call and they can, reach out to at the last minute. I have a patient here. What's going on? And I'm not getting back. I can't get back in the same 30 minutes all the time. But when pharmacies text me, I'm calling them or texting them back within the same day, so that they they have that continuity and they have someone to rely on. And I need it too. I mean, we all need it. We need the easy button sometimes. I call someone up and I'm sorry, I know you've emailed me this. Where is it?
Josh is my easy button usually.
There you go.
Like,
well, and one of the things, we've spent a lot of time really over the last couple of years building out infrastructure in Pioneer to be able to communicate well. And it just goes to show that like, that's clearly the right answer, right? We have to be able to give pharmacists the ability to communicate with each other and across networks very, very quickly. And like, there's just not a good option. Like iMessage is cool, but that can't be the only option.
You're right. And that actually reminds me, we are doing a research evaluation of Flip the Pharmacy Cohort 1. So it's just the first year of the, it's from 2019 to 2020. And I am transcribing, and I was part of some of these interviews. But one of the things that was mentioned was we were asking a lot of questions about the setup. Was it effective? How do we measure effectiveness? Like, how did it actually work? I mean, we knew what the plan was, but how did it actually work in real life? And what was most successful and impactful for the pharmacies? And it came out in one of the messages, they all use this thing. I wasn't familiar with the program, but they have a program through that they can talk to each other, and it is an instant message through their computer, like what you're saying, Josh. I think it's very similar, and then all of a sudden the light bulb started clicking off for me. I'm like, oh, that's how they were sharing everything, and they were like talking every day in the group, and it you could see it in the rest of their answers then about how well it was working. It was really down to that. In a minute, in a pinch, I'm sharing something, they would hop on and they could get on, like, do a quick 5-minute just call or conference call with like 5 people at a time, or they could just use it through the chat as well. But it was connecting all the different stores. So communication is key.
Like Slack or something like that. A lot of them I noticed use Slack.
Yeah.
Yes, you made me like the FDA news hit last week, so I haven't really thought about it too much. But that's true. This week you're probably getting inundated with. Is it released for the 5 to 11-year-old group? Well, that could happen as we're on this call. Like, it really could. It
really could happen while we're on this call. They, at the moment, it's the first opening up, which is so strange. They're doing this in waves, but it's different than the first waves back when early 2021, end of 2020, where it was like a wave meant you're getting this week, and the next wave might not be for 4 to 6 weeks. This is days. So I'm just like, okay, we don't have to panic anymore. Like, yes, they're getting it on Wednesday, but you're going to get it on Thursday. Okay, if you're not in wave 1. So like the jurisdictions are all getting kind of the first order out. Then the federal pharmacy partners are getting theirs. So the pharmacies in our state, the earliest they'll get vaccine is Thursday. The latest is Friday of this week.
Okay.
And then they're getting some on Saturday. But all of that is waiting on this afternoon CDC to say, okay.
Right. Yeah.
But everything is in place. So once they say, okay, we just hit a button like everybody, that's the current dissemination plan.
She's got a group text.
I'm like
pre-ready. I've got a group text.
pre-primed, ready to go.
Yeah, she just got to hit send. Yeah.
I was like, man,
exactly.
My 4-year-old looks like she's 5. I'm go up to Arkansas next week, and I'm joking. I won't break the law.
I won't break the law. Don't break the law.
Yeah, one thing I watched the Pfizer put out some training videos, and so I watched that for an hour yesterday. They're great information. It's just kind of hard to get through it all. But they, it's just not most fun webinars, but they,
no.
we're now going to be referring to Pfizer vaccine as purple caps and orange caps. Like it's going to be part of our normal vernacular. Is the purple cap or an orange cap or a gray cap? They're going to different color caps. But one of the things that it's funny when you mentioned about 4 to 5-year-olds, and they did emphasize it, but I walked away going, oh, this is going to be a long-term, like, I'm going to have to probably put out some little tips or reminders about this. The people who are on the bridge are from 11 to 12, because this is approved from 5 to 11, and then 12 and overs for our adult doses. Folks who are turning 11 right around that or in between their doses. I mean, that I feel like there's going to be a lot of re-education
Do you step
around
up
that.
to the next dose?
They could actually do either dose, is what they said on the webinar. Now, of course, this making sure this is what is today? November 2nd.
As of today, right? Not when this is
1:43
released.
p.m.
Right.
Yeah,
Right.
there
Right.
hasn't been approved EUA yet at this point, but as of what they had submitted, it was you could do either the adult dosing or the pediatric dosing, or you could do any combination. It almost felt like so. That'll be fun for those folks who are right on the bench.
Right. I'm still, I mean, like I said, I have a 4-year-old, so I'm anxiously awaiting the 6-month to 5-year EUA.
How much longer do you think on that?
It's funny, when I was reading, the best answers I've been able to get are from stock analyst reviews, because they're obviously paying close attention to what's going on at Pfizer. So they were estimating that they were probably 2 to 3 weeks behind the 5 to 11 year, but we've
That
I mean, who knows? That's stock analyst. I mean, they were doing the studies at the same time.
Yeah,
So
yeah, that quick. Huh.
all you really have to do at this point, after showing that, hundreds of millions of people have been vaccinated successfully, is that it doesn't specifically do anything weird to kids. So who knows? It might be 2 to 3 weeks. I hope it is, because I'll feel a lot more cavalier about going out into the world.
Yeah, same for me. I heard this. That's a much better reference. This was just from someone else who told me that they had heard it was by the end of this year we could expect to have it. So,
We're waiting.
We just run around and start jabbing.
I think that those of us who are going, like those of us who are early acceptors or adopters, or however term you're going to use, like we're all ready to vaccinate our kids, but I know there's still a struggle with hesitancy, and so we're still trying to knock on that door. I mean, we're only sitting at, I think, 50% vaccinated in Arkansas. So it's just, and it's not the people who want to get it, who got it the very first day, they're the ones going to vaccinate their kids.
Yeah.
It's everyone else of just.
I'm just going to say, how many kids do you know that died of polio? None.
Yes, none.
It's a no-brainer. I'm like, come on.
So you're also, we'll get into, so that's like, what else? I know CPESN for you, for the most part, has probably been all that, right? For the most part, like that vaccination efforts. What about with the monoclonal antibodies? Are you guys have to be as involved there?
I feel like my network forces me to be involved.
Nice.
But they just, I've said that very lovingly and very lightly, but they're very, they jump on the gun with things. And so I almost kind of have to at them, because the people are going to ask me questions. I tried, Mark, really, really hard in the beginning to just go, you know what? I'm not going to learn about this.
You guys got this.
Somebody else can do it.
You guys got
y'all want to offer monoclonal antibodies, you do it. I don't even want to go down this route right now. Like there's so many. Number one, I mean, there are, what I do for CPESN Arkansas can be a full-time job.
For sure.
And it's not a full-time job that I'm spending. Like I do spend a good portion of my time on it, and I try to align what I say yes to and all of my hours around, servicing them. I can turn that into my teaching, then I can turn that into my research.
Sure.
Like they're not all completely separate things, but they do require, their own time as well. So number one, we need more folks. We need more academicians. We need more pharmacists and more staff in pharmacies to be involved, not pharmacies, pharmacists and faculty to help community pharmacy. We need more of this. And there's a lot that we can do with supporting our teaching aims as well as our research aims. And there's just you can make a career out of this. That's something that we're having to tell the academia side. They're just thought that they don't think you can make there's a rumor that, there's not a career in community pharmacy as a faculty member. And I'm like, here to show you, yes, you can.
Clearly.
Right.
Clearly.
Well, I went to a pharmacy school where that was not a rumor. That was a stated fact. So, yeah, I give them a hard time about that whenever I see them, but it's...
Other colleges?
Well, no, when I talk to faculty from the University of Texas, I'm like, guys, when I was in pharmacy school, and still to a degree, if you didn't go do a clinical residency and work in a hospital, you are wasting your time. And that was just decidedly untrue.
Yes, and I agree with that. And I feel like we need to do a better job of highlighting the great career that community pharmacy is, and we can do more support to CPESN networks like this. So, or CPESN networks can have their hire their own executive. If we get the revenue streams figured out, they can hire their own executive director and probably take a lot of what I do off my plate. But monoclonal antibodies I was like, okay, it was beginning of the fall. I have new classes and new things. So I was just sort of like, I need to just say, like, y'all got this, right? You've got this one. I don't have to do it. And then, but because some of the pharmacies in Arkansas were the first ones to just start it, giving it, I got the ask from CPESN USA, hey, can you lead a weekly webinar about monoclonal antibodies?
You bet.
So yes, I got involved and I ended up learning about it. And I said, okay. So one of the things that CPESN does, depending on whatever the it is thing at the time, at one point it was point of care testing, for when COVID testing kind of really took off and people got interested in that. Another one was, immunizations. They would do this, a series called Workflow Wednesdays. And it's kind of had a couple of different looks. Sometimes it was just an email with attachments. Sometimes it was a video. Sometimes it was a live webinar. This time it's been a live webinar, really as a learning collaborative place where folks can quickly, hear of someone that's in another state that's actively doing monoclonal antibody therapy or giving it, or are they doing home visits? Are they doing infusions? Are they doing sub-Q? How do you actually set it up? What's the extra staff that you need? They could quickly kind of get on and learn from each other. So I don't have to be an expert in it, but I'm bringing those folks together, and then I'm writing down and taking all of their advice, and we're putting it into what we're calling a change package. To me, it's just a list of best practices. How do you actually implement this in a community pharmacy setting? And that is being updated every week on flipthepharmacy.com.
Gotcha.
Flipthepharmacy.com at the top has a banner, and it'll have our change package there. So you can see all of the areas of personnel, and then how do you actually do it? How do you think about customer experience? Because apparently it was really helpful to have snacks and water on hand. They're with you for a long time.
That makes
all
sense.
to build.
They're not only with you for a long time, but I was shocked when I was looking through the stuff, like the infusibles for monoclonal antibodies make sense, right? That's where they were intended. But the sub-Q injections, you're injecting like a huge amount of volume. It's like,
huge.
It's nuts. Like normal
2.5
sub-Q.
mils.
Yeah.
Oh.
Dude, like, so normal sub-Q, you're looking at 0.1, 0.2 mils.
Right,
you're looking at 2.5 milliliters. Like you're infusing, you're putting in a lot of volume.
Yeah.
2.5 milliliters
Multiple-
and 4 injections.
Yeah, I was going to say multiple injections, right?
Across. There's four 2.5 milliliter injections that you have to administer, and it's very viscous too. It's hard to draw up and deliver, but you don't want to be too slow. You don't want to be too fast. We do have that in our thing as well about how long it should take you to depress it. I think it was like a minute. You had to depress 2.5 mils but yeah.
Well, could you imagine trying to do a 2.5 mil fast push? Like that would be uncomfortable at best.
Very uncomfortable. Nobody, that has been one common thing that we've all been worried about, but none of the patients have reported discomfort with the sub-Q. Like, even though it must feels like a whole lot, it looks like a lot. But yeah, the patients are fine with it. They're like, oh, it's all right.
When you feel,
now
it's for COVID patients too,
like,
probably. At the same time, I'm like, probably feel like crap. So you're like, just do it. Just do it.
Well, I've heard, they do feel like they do feel terrible. And even before they leave you, I've heard the stories from these pharmacists are like, before they leave their clinic or their waiting area, they're feeling so much better. Yeah. Like it's really fast. How the effect that it has on patients. So yes, I do know a little bit about that, and just kind of.
It sounds like you were the person to ask that question too.
We're going to continue these monoclonal antibody therapy workflow Wednesdays until we.
So you don't need them anymore?
It's not needed. We have it planned right now through the end of December. We're not sure if we even need to go that long, to be honest. But all of the information is available in the Sunday updates as well. So if anybody's in CPESN receiving those weekly Sunday update emails, there's in there as well. All the past webinar recordings if you want to hear about it. Now, another thing we cover a lot of each time is billing for that one. That one's a little bit tricky with the billing. It brought to the forefront again, which is something that I've heard about and seen and had a barrier for many years, is how do you do medical billing in a pharmacy? And I have to explain that to students in a way they'll understand too. They're like, what? I'm like, I know, we don't really talk about billing.
That's true.
We just process prescriptions. So we process prescriptions, and that you can adjudicate right then. Medical billing is not the same, and it doesn't use the same process. And again, we're shifting with the expectations, and how do we make this infrastructure work for these new types of services? And we have to do that, honestly, in order to really take advantage of that. If we can get national provider status ever, when we get that, we're going to need our billing processes in place. Just getting into the legislation is not going to change your practice overnight or in a week. We'd still need to work through how to perform medical billing, and whether that's your subbing it out and they're contracting it out, and that's what several of the pharmacies are doing with monoclonal antibodies, is they're just contracting out for another medical billing company to submit that on their behalf.
Right. Well, and just as important for that though, like you have to be able to figure out how to do medical billing for pharmacies, but you're going to have to make it easy for the insurances to be able to work with pharmacies. Because no matter how much you change the law, if it's hard for insurance companies to work with you, they're just not going to do it.
True. Absolutely. That same sentiment is the same with credentialing. And I had to learn a lot more about that with, insurance credentialing of like, well, we're allowed to bill for this. Like, well, you're not credentialed with us, and this is what it looks like. Right. And even that process, I was surprised how long that could take. So anyone else listening, if we need to start that process for you on the pharmacy side, could take you just as an applicant, you need to set aside a few weeks to figure that out to even apply. But then into the insurance companies, it could take them a year to actually get it all through. I thought that was really surprising to me. It takes a year to process the application in some cases. That's not all cases, but in some cases. But that's just another hurdle of how are all these pieces connecting, and how are you communicating across these different systems? And our entire setup what we've been doing as a pharmacy business just hasn't been made for this. So it makes sense to me of why we're kind of coming up on some roadblocks, and we're having to figure out, build our bridges and all that. I mean, I was like, we're never set up that way. We need to now because we want to. Yeah, there's need for that. But yeah, there's we're same for workflow, and I think that Pioneer has done, and I know is actively working on a lot of ways to continue to enhance workflow. This is something how I share with my students, that workflow at a community pharmacy is built around the efficiency to get the prescription filled. That's what it was. Now we have to, what is the workflow for all these other patient care activities you want to do? So it's a whole different, it's a different task. It's a different end goal. It's different. And we've talked a long time about, we meaning, as a very general, but just kind of in my circles and what I've been seeing in conversations at conferences is how do we integrate patient care, that whole integrating to workflow. How do we integrate into workflow? And the other day I just had this thought of maybe we just don't. It's just so hard to integrate. I was like, we're taking this really hard, thing that's been very efficient, and now we're trying to add in all these other pieces. Maybe the adding in and tweaking and pushing, like, I don't know, maybe that whole idea of integrating is not, maybe something's missing there. I feel like we would maybe have solved it by now. I don't mean to be cynical about any of our technology for folks about that. What I'm thinking more of that the workflows require a different workflow. Like,
Right.
and I'm not saying that you would have to have a different system or you can't, a Pioneer can't do it.
Right. I know what you
I
mean.
don't mean that at all. But what I mean is the process of what does it look like for a prescription to be entered going from A to Z? Instead of inserting our clinical into there, it's like we have to have a clinical workflow track on top of this. It's probably just different. We're going to use both, but it's going to be a separate roles or responsibilities, what's happening, who goes where. I mean, the documentation might be different.
Right.
We could use the same system, but trying to figure out, okay, well, when a prescription comes in and then I'm filling it and validating it, then I'm going to do this part of my clinical part, and then I'm going to call the patient, then I'm going to stop here and do this. We've patched it together. I think we have some things that work really well, but chronic care management, it's just not working very well right now. What
Right.
I'm seeing, I'm like, it's hard.
Well, it's a lot like, we address workflow in that regard where you can do filling and clinical is either integrated or asynchronous. And I think the way I kind of look at that differentiator is if you've got one pharmacist and one technician, it has to be integrated. If you've got a certain number of volume or a bunch of different activities, just like MedSync, you can sync your patients and do refills with one person. But at a certain point, the volume becomes such that you have a regular waiter workflow, and then you have a MedSync workflow that's operated by a separate person. And I think in that boat, you have your clinical services people in an ideal world that exist outside of that workflow, but your workflow can trigger those things at certain points, right?
Exactly.
And that's the trick. Nobody's there yet, but I think you have to work to that point because you're right. I don't think you can do all of the things that you need to do all the time, right? It's just not possible.
Right. Well, I mean, it's how many services are you doing, or what is the business model you've set up, and with that staffing, if you have the one pharmacist, one tech, like you're saying, yes, it has to be integrated, and then at the same time, yes, you're going to have to choose which things you're doing, right? You can't do monoclonal antibody therapy and point of care testing and genetic counseling, and you can't do that with those two people.
I'll be a little snarky and say CVS thinks you can.
Oh. Okay.
They're wrong.
She's like, I'm dodging this one. Yeah, she's like,
No,
that's all right.
you can't, as two people do there's going to be a max to that. So I love what you just said, Josh, and I think you're 100% right. And we, there are some things that I do feel work really, really well with workflow. It's just, I don't think it's working with all services. You can't just you just build upon that for anything and everything we want to do. I do feel like there's one of the pharmacies I've had the privilege of working with this last, 10 months that I've been with them. We started, they've been kind of a test pilot store for me since the beginning, but in the last 10 months, I've really helped them and became part of their team with providing vaccinations. And so, Josh, I invite you back to Arkansas. Come visit the store if you haven't visited them already, because they have a separate staff for each of their clinical workflows. And I think that is what's so cool. And I've been there every week. I do there 4 hours a week, and my role there is to give vaccines. So I do their vaccine clinic each Wednesday. That's me. And then they have they have more staff. They have I have like 4 or 5 pharmacists there on any given day, and they all have their own unique pockets. Like mine is vaccines, and then I also do point of care testing. But then when I'm not there, there's a designated person that they're responsible for the vaccines, or they're responsible for their bubble packing, and also their workflow is they have 80% of their chronic fills are on or synced. So they're very proactive, and it's changing that mindset of that workflow that's being very proactive. That's helped them a lot, they've said. And they like I was there on Wednesday, they were working on Sunday fills. So it just having that kind of change of everything's not a fire, like everything that's going on in the pharmacy, but they're not fires that have to be dealt with right then. It allows them that opportunity to go into monoclonal antibody therapy, or to think about something else and add that on.
And that's one of the important things. And we tell almost every pharmacy that gets pioneered this, they're like, I'm ready to start care planning. Well, not until you've got most of your patients synced. right? Like that has to be the
Just won't have the
foundational
room.
part.
Is that what you're saying? You won't have the you won't have the air.
Yeah, you have to free up the time to be able to do other stuff, and you can't do that if all you do all day is firefight.
Exactly. Yeah. No, I can see it with them, and I think more people need to see that. And it's hard. I know it's hard. If they're going from zero to making that transition, it's very awkward. I actually just summarized Flip the Pharmacy up in that way. And I thought, actually, it's probably a good way to summarize it. Like, what is Flip the Pharmacy? I was like, it's that awkward time after going from one business model to a whole different business model. Like, this is Flip the Pharmacy. It's very hard and awkward because you have 1 foot here and 1 foot there, and you're trying to figure out how to pivot to some of those other goals that you have or services you want to provide, or, incorporating and now thinking proactively about your patient base rather than who all's there. One of the things that Troy Trigstad says at several talks or conferences that he's at, he says, it's not about the person who's standing right in front of you that day. You got to think about everybody that you're servicing, not the ones who are just in the pharmacy that day or just in the store. So it's that mindset changing, and how are you taking advantage of your opportunity with those patients and with that patient base that you're serving. So I agree 100%. You have to do this MedSync, and if you've never done it or set it up, or it's going to be hard in the beginning.
Right.
Just to get there is awkward. There's going to be awkward stages.
Yeah, we talk to a lot of people, and like when you first start it, it's going to be worse until you get to about 25% of your chronic patients synced. It's going to hurt.
Mm-hmm. Well, you had asked me about monoclonal antibodies. You're saying, I'm sure you're doing all that with vaccines. And yes, that kind of took over a lot of my time and attention when we needed to roll that out. And I do serve as our state lead for that. But I thought what you were going to ask was, is there anything else that you do?
Well, I know you teach. I know you have all of this other stuff. Yeah, absolutely.
There's some other stuff. And if I could just plug a little bit into if it hasn't come through strongly enough, I really want to encourage the relationship between community pharmacies and academia. And not all academia is there yet, and I'm fighting a good fight to get them there, to show them the value that community pharmacy is and the value of working together. If you've not made that connection, to call out, make a connection. If you need a starting place, the Act for Pharmacy, it's called actforpharmacy.com. It's the ACT Collaborative, the Academia and CPESN Transformation Collaborative. That one, the first kind of goal of that was just to connect people. So if you want to know who to reach out to at a local college or school of pharmacy, you can go to actforpharmacy.com, click on champions at the top, and it'll give you a point of reference, a point of contact. This is the person who is interested in community pharmacy. So if we haven't made that yet, there's a connection for you. I also run a residency program and facilitate that. And so I think that there is a big opportunity with enhancing community practice through residencies and postgraduate training. That can be a way that you can maybe take that next step, maybe without hiring a full on new staff, but that you can get a lot of benefit for using a trainee in these settings. I view residencies as a learning opportunity for the residents, but then they also are giving back, and every one of the businesses should be better by the time that resident leaves every year. So we always look for synergies of how that resident can help the business grow year to year. So that's just another opportunity that community pharmacists can, relationship opportunity that they can take to help grow what they're doing. I love community pharmacy.
That's definitely going to end up as a snippet. You realize that, right?
Yeah.
Anecdotally, I think that tracks well with what we've seen at Pioneer. I work with several Flip the Pharmacy
Stephanie,
cohorts.
Aaron, Jordan.
Yeah, I mean, every single time you have an engaged,
Megan.
well-run Flip the Pharmacy cohort, it's because of a strong academic connection. That's Arkansas, that's Georgia, that's Mississippi, that's Pennsylvania. And that's the common thread, right? You have somebody who's there to help back them up, help facilitate, write down, make sure you're catching all those little things about how to do this, and really kind of coordinating those efforts. So I totally agree with you. Like getting the School of Pharmacy that's around to be more engaged in those communities is massive.
And they're typically better at like writing, I would think.
Yeah,
like
better at writing grants.
Writing
right?
grants, right? Like writing the thing, to go get money to do a PMPM for XYZ or something like that, right? They're typically that's what they are better at.
Yeah.
Yeah. I try to take off what I do and get in as many places as I can to just share that story. But publications is one of those. And I did a Pharmacy Today article about how you can use your students on rotation. So if you already have, having students, that's another area that tends to get I wouldn't say it's ignored or anything. It's just, it hasn't been thought about in that way of, hey, you can use rotation students who are coming to you. It doesn't have to be a one-way street. They can definitely help you as well. And so I've designed a few rotations where the students are part of Flip the Pharmacy and are giving back to Flip the Pharmacy. Josh, you're going to get another invite, probably tomorrow.
Another student presentation.
About our
All
sponsor presentation. Yeah. So it's, but how we use the students to benefit and help advance practice too. And they get a lot out of that. So, they do still obviously need to make sure that they're going to, that their patient care skills are, they're getting practice in that, obviously, but you don't have to kind of pigeonhole them per se. I've had several conversations with some community pharmacies who are like, oh, I can have the student do that? I said, yes, your student can do that. So of just ways that they're like, I don't even know if point of care testing is for me. I said, well, give that as a project to your student. What questions what are your barriers? What are things that make you nervous? Have them find the answers. Or go to that conference or sign into that webinar that you don't have time to sign into. Have them do it and report back to you. Yeah. And they thought, this is amazing. So, they're another great, great resource too.
Yeah, think about all the research you get to do when someone else gets to do it for you.
Right.
Yeah. Well, a lot of the times I'll use interns to do that.
Yeah.
There's another group I'm a part of called the Rural CP. It's a rural community pharmacy practice-based research network. It's in 5 states: North Carolina, South Carolina, Georgia, Arkansas, and Alabama. And then we're expanding to Tennessee and Georgia. Did I already say Georgia? Anyway, we're expanding to them, but it's for rural community pharmacists, and that is exactly what you were saying, Mark. Of the whole point of that is to write grants to get them money. So we can practice, show what's working in rural settings, and get them money for doing and helping us advance. How do we address right now? Kind of the things we have in the pipeline, or how do we address vaccine hesitancy in rural communities? And so we get the community pharmacies to partner with us to try the interventions and make that study. But then we also have the study. We're paying them for that too. So you don't have, it's a no cost, venture, but trying to set up more networks like that, I think that's kind of what, for me, CPESN is. To me, it's my laboratory per se, and that rural network is a laboratory that's actually has some really well experienced researchers that actually can get NIH grants. So we have a few of those in the line.
Nice.
But it's doing exactly what you're saying.
Awesome.
I'd love to challenge Scott Payson. I'd love to come back.
Ooh. Dude, we could do a duel.
Yeah.
Well, hopefully at some point, maybe we could do a remote podcast from Arkansas or something like that.
Oh, that'd be cool.
I'll go visit, and you guys can duke it out.
All right. That'll be fun.
Well, Megan, you're amazing.
Oh, thank
we
you.
all knew that, but now everyone else does. And
thank you so much.
And thank you so much for being on and everything you're doing community pharmacy wise. It's a community we serve and stand behind, just like you do as well. So thanks for spending time with us today, and we'll see you out there.
All right. Thank you. Take care, everyone.
All right. Bye, everybody.
Thank you for watching the Catalyst Pharmacy Podcast.
If you enjoyed today's episode,
please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.